going live. Just a moment. Okay, good evening, everybody. We are now ready to start our second journal club. One of the dilemmas that embryologists face is, should we go in for blastocyst culture or not? And there are many pros and cons to that. More and more of us are getting into blastocyst culture naturally for the higher pregnancy rates per transfer. But sometimes there's a concern, especially when we have very few blastocysts. Do we take the risk of going for blastocyst culture and finding that we have no blastocysts available for transfer? It's a dilemma often faced by the clinicians as well as embryologists. So in this journal club, we have Dr. Sujata, who is going to be discussing a paper published in the last RBM Online about whether to go for blastocyst transfer when you have just 1 to 3 blastocysts. So without much ado, over to you, Sujata, for the. So she is going to be the speaker, and we have Dr. Gaurav and Dr. Varsha Samson Roy, who would be discussing, and later the floor will be open to everybody to ask their questions. So over to you, Sujata.
So can you see my screen?
Yes, you can go ahead.
Yes.
So good evening. Thank you all for being here this Saturday evening. As Dr. Rajvi said, the article is, should blastocyst transfer be performed in patients with 1 to 3 embryos available on day 3? Now, she had already given us the background, but just to reiterate, we all know that the field of IVF has undergone tremendous changes in the last 2 decades. The process, the efficiency of the process is improved, and we also have very well-defined goal now. Earlier, our goal is just to get the patient pregnant, but now we want a single live, healthy pregnancy, healthy live birth. Now, to achieve this goal, our experience and the evidence tells us that we have to transfer embryo at the latest developmental stage, which is the blastocyst. Now, there are a lot of advantages for blastocyst transfer. It improves uterine and embryonic synchronicity, and it enables selection, self-selection of viable embryos. And there are a lot of evidence in the literature. I've just, highlighted few of them here. There is low quality evidence to show that live birth rate following fresh transfer is higher in the blastocyst transfer group. There is moderate quality evidence to show that the clinical pregnancy rate is also higher in the blastocyst stage transfer group following fresh transfer. The embryo freezing rates are much lower because, many times we do not get blastocyst and then they just get arrested. And this is one of the major pitfalls where when you advise for a patient for blastocyst transfer, because there can be failure to transfer any embryo in the blastocyst transfer group. And here we have moderate quality evidence. Now, there are 2 schools of thoughts here. One, people say that the aim of any IVF treatment is not to have an embryo transfer, but to have a live birth, which the chances are better when you transfer a blastocyst. But the second school of thought is, suppose if you're transferring a zygote or you are transferring a cleavage stage embryo, we cannot say that the chance is nil. There is still, say, even though if it is less, there is still some chances of pregnancy. If you do not transfer, then even that chance you're not giving it to the patient. So, there is always a debate whether to take the embryos to blastocyst or just do the transfer at the cleavage stage. Now, this debate is more pronounced when you do not have many embryos. When you have just few embryos, the question is, whether to do a cleavage stage transfer or to do a blastocyst stage transfer. Now, the American Society of Reproductive Medicine had commented that blastocyst transfer improves pregnancy rates only in good prognosis patients, whereas in poor prognosis patients, it is either ineffective or can be harmful because of the fewer number of embryos available. This was in 2018. We have again made quite a lot of progress since that time. But the thing is, like in spite of all this, there is still so much of pressure from the industry as well as from the patients to opt for blastocyst transfer. And here, see, all clinics may not have the same kind of culture conditions. There could be a lot of variations, could be very small, but these small variations can have a significant impact on the formation of blastocysts. So with this as the background, this paper has tried to answer a question like in patients with 1 to 3 embryos available on day 3, does blastocyst transfer reduce the chance of clinical pregnancy by cancelling transfer cycles when compared with cleavage transfer? Just give me a second. I just want to. So the study design, this is a retrospective observational cohort study. It's registered in the Chinese Clinical Trial Registry. Ethical approval was taken. And they have included all IVF cycles performed from January 1st, 2019 to 31st December 2020. So 2 years of cycles which are being done in the Center for Reproduction and Fertility of the second affiliated hospital of Kunming Medical University. So what they have done is, on day 3 after oocyte retrieval, all couples were counseled by an embryologist about the number and the grade of embryos. The patients were informed about the advantages and the risk of extended culture to blastocyst stage, especially like when you have the risk of reduced number of available embryos and the risk of not having an embryo transfer were informed to the couple. So in cycles with at least one good quality embryo, the decision whether to do the transfer on day 3 or on day 5 is taken by the patient with the embryologist. In cycles without any high quality embryo on day 3, extended culture is routinely performed, and that is not included in this analysis. Now, inclusion criteria. Only cycles with blastocyst quality of 3CB and better undergo transfer, whereas the rest of the cycles are cancelled. Cycles without any good quality embryo on day 3 were excluded. And inclusion criteria for cycles were as follows. Only 1 to 3 embryos on day 3. At least one of them should be of good quality. And they have also used up whatever embryos they get in one cycle. It's not that like they have transferred one and they have frozen for a subsequent FET. Whatever they have got, that was transferred either in the fresh cycle or in the FET cycle. Now, ovarian stimulation was performed based on the regular process, which is followed in their center. Oocyte retrieval was done at 36 hours. Embryos were cultured in G-series media, Vitrolife, according to the manufacturer's instructions. And on day 3, the embryo was scored based on the number of blastomeres, the degree of fragmentation, and the symmetry of blastomeres. So when they say good quality, it is defined as the embryo with a minimum of 6 blastomere on day 3. Now, in the blastocyst transfer group, the blastocysts were scored on day 5 and day 6 according to the Gardner and Schoolcraft classification. These embryos were used for transfer either in a fresh cycle or in a frozen thawed cycle. And patient characteristics, no differences were observed in terms of age, antral follicle count, anti-Mullerian hormone level, FSH, body mass index, infertility duration, number of previous transfers, or the type of infertility between the two groups. In both the groups, fresh embryo transfers were performed in patients with an endometrial thickness of greater than 7 millimeter, and when the serum progesterone concentration is less than 2 nanogram per ml. If this criteria is not met, then vitrification is performed. I hope it is clear until here. So the decision to do a cleavage stage embryo transfer or a blastocyst transfer is taken on day 3. They counsel the patient and the decision is taken by the patient along with the embryologist. And they should have at least one good quality embryo on day 3, then they are included in the study. If it is not there, they are not included in the study. So what is the outcome? The primary outcome was ongoing pregnancy rate. And when they say ongoing pregnancy rate, it is defined as the number of ongoing pregnancy cycles greater than 12 weeks per day 3 cycle. Per day 3 cycle is the starting point. Secondary outcomes were clinical pregnancy rate and embryo cessation rate. Embryo cessation means the number of embryos which stop developing before 12 weeks after transfer per day 3 embryo start cycle. Clinical pregnancy rate is defined as the number of clinical pregnancies cycles per day 3 cycle. Now, what are the statistical analysis which is done? So all this data, this is a retrospective analysis, and hence all the data were obtained from the clinical medical records. Continuous data is reported as mean plus or minus standard deviation. Wherever they did comparison, that was performed using an unpaired man-Whitney U-test. Categorical data is reported as percentages, and comparisons between these groups were performed using Fisher's exact test. Differences with less than p-value less than 0.05 is shown to be statistically significant. They have also performed multiple logistic regression analysis to show the association between transfer stage and ongoing pregnancy rate, which is adjusted for the number of good quality embryos, age, and the number of previous transfers. Because age, previous transfers, and the number of good quality embryos are major confounding factors. So that is why they have performed multiple logistic regression analysis to overcome that. Now, what are the results? So if you look at the outcome, so the number of cycles, okay, on day 3, the starting point, where people opted for cleavage transfer were 267, and for blastocyst transfer, it is 156. The number of embryos available at that point were 557 in the cleavage transfer group and 351 in the blastocyst transfer group. Number of good quality embryos are almost the same in both the groups, 70%, 70%. A number of blastocysts formed from these 248 day 3 embryos were 220, that is 62%. Out of these blastocysts, the number which were available for transfer, that is good quality, is 189, which is 53% from the starting point. Cycle cancellation, there were no cycle cancellation in cleavage transfer group, whereas in the blastocyst transfer group, 38 cycles were cancelled, that is 24%. Almost 1/4 of the cycle are cancelled. Number of cycles where embryo transfer was done, it is 267. So whomever opted for day 3 transfer, they underwent embryo transfer, that's 100%. Whereas in the blastocyst transfer group, there were 118 transfers, that is 75% of the starting point. Out of this, fresh transfer was done in 133 cycles, that's almost 50%. And in the blastocyst transfer, the fresh transfer cycles were 42, that's only 26%. FET cycles, it's 134. Again, another half of it in the cleavage transfer group was FET. Whereas in the blastocyst transfer group, 76 cycles were FET cycles. Total number of embryos transferred were 516 in the cleavage transfer group and 189 in the blastocyst transfer group. They have also given the number of embryos transferred both in the fresh and the frozen cycles. And the number of embryos discarded, that is in cleavage transfer, like say when they have extra embryos, these embryos were discarded with the patient's consent. So 41 embryos were discarded, that is almost 7%. Whereas in the blastocyst, almost 162 embryos were discarded because of the quality, and then they didn't use it for any further cycles, that is almost 46%. So this is the initial outcome. Now, if you look at the cycle characteristics, the cancellation rate, as we saw in the previous table, in cleavage transfer, it was nil, whereas in blastocyst transfer, 38 cycles were cancelled, that is all 24%. The p-value is less than 0.001, which is, statistically significant. There's not much of a difference in the number of oocytes retrieved. It's almost the same in both the groups. Number of embryos on day 3 is again, in fact, the blastocyst transfer group had more number of embryos on day 3. And the number of good quality embryos also is, found to be more in the blastocyst group, though it is not statistically significant. The number of embryos transferred per cycle is 1.93 in cleavage transfer, whereas in the blastocyst transfer, it is 1.60. Embryo utilization rate is very high in the cleavage transfer group, that's 92%. And in the blastocyst transfer group, it is only 53%. Now, these embryos transferred per cycle and embryo utilization rate is also statistically significant. So they say that in the blastocyst transfer group, 162 day 3 embryos arrested, resulting in the cancellation of 38 cycles. In the present study, cancellation rate is defined as the number of cycles without transfer, and embryo utilization rate is defined as the number of embryos transferred per starting cycle. Cancellation rate, as I said earlier, it's increased significantly. Now, if you look at the main clinical outcome, so the ongoing pregnancy rate is in the cleavage transfer group, it is 25%, and the blastocyst transfer group, it is 26.9%. And the ongoing pregnancy rate per embryo transfer in the cleavage group, it is 25% again, and in the blastocyst transfer group, there is an increase 35%, but it is not statistically significant. Sorry. If you're looking at the clinical pregnancy rate per cycle, that is per starting cycle, okay? That is what they mean by per cycle. And in the cleavage transfer group, it is 32%, and the blastocyst transfer group, it is 30%, not much of a difference. Whereas if you look at the ET, for every ET which was done, the clinical pregnancy rate is 32% in the cleavage transfer group and 40% in the blastocyst transfer group. Here again, you see a slight increase in the pregnancy rate in the blastocyst transfer, again statistically not significant. Implantation rate for starting point is almost the same. In fact, it looks slightly better in cleavage transfer group. It is 19.75%. In the blastocyst transfer group, it is only 15.95%. But if you're looking at implantation rate per embryo transfer, and it is higher in the blastocyst transfer group, almost, like 10% more. And the value is not statistically significant. And if you're looking at the multiple pregnancy rate, and in the cleavage transfer group, the multiple pregnancy rate is only 10.88%, whereas in the blastocyst transfer group is 12.5%. If you remember, the number of embryos transferred is almost 1.9 in the cleavage transfer and 1.5 in the blastocyst transfer group. And embryo cessation rate, that is missed abortion, if you see, it is almost the same in both groups, 83% in cleavage transfer and 85% in the blastocyst transfer group. So if you look at the discussion, the ongoing pregnancy rate, clinical pregnancy rate, and embryo cessation rate were evaluated in poor prognosis patients with 1 to 3 embryos available on day 3 who underwent embryo transfer either at the cleavage stage or at the blastocyst stage. They say no difference was observed in these parameters between the groups. So they say, like in poor prognosis patients with 1 to 3 embryos available on day 3, blastocyst transfer neither decreases the chance of clinical pregnancy nor decrease the number of viable embryos. This is the conclusion they're trying to make. Now, what are the limitations of the study? See, one, this is retrospective analysis. Now, what, in my opinion, the major limitation is the transfer stage is determined by the patient. There are a lot of confounding factors, like in making the decision. It could be, the knowledge or the kind of counseling given or the financial constraints, all actually could have been a part of this decision. So that I find it's a major limitation of this study. And then, though they have done a multiple logistic regression analysis, still there could be patients who would have had previous transfers versus patients who would be having their first transfer. And we all know that in patients with previous embryo transfers, the results would be slightly lower than people with the first attempts. And the last one is, this is a single center study. So, you can't make a conclusion based on that unless, the culture condition can be mimicked in other centers as well. Now, my thoughts on this particular paper is not on the concept, but on this particular paper is cycle cancellation is significantly high in day 5. So, and then they have said that blastocyst transfer neither decreases or the chances of pregnancy nor reduces the number for transfer. But then I don't see the actual benefit. It's just the same between both. In fact, you lose more embryos in the blastocyst transfer group than in the cleavage stage transfer group. So the pregnancy rate is almost the same. Then what is the point in culturing these embryos for 2 extra days? Then again, like if you're doing blastocyst transfer, the idea is you reduce the multiple pregnancy rate because you transfer less number of embryos. But then here, if you look at it, though statistically not significant, the multiple pregnancy rate is it's almost the same. In fact, it is higher in blastocyst transfer group. Now, another thing which I also want to say is, though the clinical pregnancy rates look better in blastocyst transfer, but if you look at the missed abortion rate, it's almost the same. So when it comes to, many of the studies have shown that when it comes to live birth rate, it's all the same and we do not see much of an advantage. So with this, I leave this paper open for discussion. Thank you. Dr. Ajvi?
Yeah. So over to you, Gaurav and Varsha. Over to you, Gaurav and Varsha, about the discussion on this paper.
So it was an interesting paper, and a very pertinent question asked. So as I was hearing Dr. Sujata here making her final conclusions, so that's a valid point that she made, that it was surprising, rather interesting to see that the multiple pregnancy rate was similar between both the groups. So despite, now I would like to know one thing, Dr. Sujata, in the blastocyst transfer group, how many embryos did they transfer per
1.4 on an average.
And in the other group?
1.9.
Okay, so there were higher number of maybe 2 embryos transferred in the cleavage stage. And in the blastocyst stage, there were fewer, but still there were cycles where maybe 2 blastocysts were transferred.
Yes.
And so, one thing is very interesting, that the patient group that has been chosen for this study is actually, it represents a very poor prognosis group, because the average number of eggs that were retrieved in both the arms were only about 3.
Yes.
3 plus minus 2. So it ranges. So this, we're talking about very poor responder patients where only up to 5 or 6 eggs have been retrieved. So this entire patient population A is not here promising to be a very highly efficient group, and hence we can see that the implantation rates were very poor. per embryo, the per day 3 embryo, the implantation rates that you mentioned were only about 15 or 19%.
Yes.
Right.
Yes.
So that's very low. And so as I was, seeing these fine prints, it takes away from the significance of this result, because they are looking at patients where only 3 day 3 embryos were produced. So we are not talking about a patient cohort where we have more embryos, and hence the dilemma of whether to transfer, whether to go ahead to blastocyst or not. Like you said, these are poor prognosis patients where there are only 1 or 3 maximum 3 day 3 embryos and minimum 1 good quality embryo.
Yeah.
So in this patient group, considering that the multiple pregnancy rate is not different, so I would probably agree with you that actually taking this risk and going till blastocyst and facing a 40% cancellation did not really make a huge impact.
Yeah.
I mean, what did we achieve by
Yes.
doing that?
Yes. Dr. Varsha.
So, thank you, Sujata. You explained it so well. It was, I think it definitely helps all of us to understand the paper much more in detail. And we're discussing about, poor responders, the role of day 5 transfer against cleavage transfer in poor responders. And I think this is very important to discuss today, because I know many of us kind of believe that, and I've heard people say that irrespective, we do day 5 transfer for everyone. And, irrespective of the patient profile. And this paper actually highlights, like Gaurav said and you said, what benefit did it achieve? Right. Second, we also need to understand what we have not discussed in this paper, is that in our kind of a scenario, we do need to understand the cost burden to the patient, right? Apart from the heartache of not having an embryo transfer. Second, if there is no transfer, what is the cost burden? The cost burden for a day 5 transfer is those 2 days of extended culture. Apart from that, you're going to ask the patient to come back again for another cycle, whether with her own or donor, So that is something that is not even being discussed, the impact of the financial burden. So I think, yes, though Sujata said it as a limitation, that it, it was based on the patient's understanding that they were allowed to go for day 3 or blasto transfer. Unfortunately, this is a topic, or this is a decision which has to be done by the couple. And as you rightly said, it all depends on the kind of counseling. Having said that, what is crucial to this whole thing is, I think when we counsel the patient, I mean, I'm not very much in favor of, being very adventurous when I have those less number of embryos, right? But I think individual clinics need to deeply look into their own blastulation rates, because we all know, your own culture conditions are pertinent to your blastulation rate. So I think we should not go by the understanding that, okay, we can always, try for a blasto transfer in poor responders. As long as, if it works in their lab, it can work in my lab without me knowing how good my lab is in forming blastocysts. So one of my point, and it is an hypothetical question for anyone, if in this scenario we have to counsel the patient, what are the factors we are highlighting to the patients? Now, the couple is going to ask us, so based on what factors do you think I'm going to get a blastocyst or not a blastocyst? Right? Isn't that important? So if she's had a previous cycle with, with a failed blastocyst formation. I mean, are we still going to counsel her to go ahead still with a blastocyst transfer? So maybe not. If she's somebody with poor quality of oocytes, I mean, I wouldn't have the heart to even talk to her about blastocysts, right? So there are those other factors, I think, patient profile, which need to be considered while counseling. So like you rightly said, that is a very, the important aspect here is how they have been counseled.
Right.
So I am also not much in, I would be least adventurous in these kind of.
Acha, see one point like which, this is the doubt which I have. See, when you suppose if the patient is asking you like, okay, you are advising us to go for blastocyst culture. So if I'm saying the blastulation rate in my lab is this much, okay, that is the blastulation rate in patients of good prognosis, where the number of oocytes are quite high. Can I extrapolate that number to these kind of cases and say confidently?
They're showing it for this patient population, that here when they did a blastocyst transfer, it did not, despite the cancellation rate, when the embryos managed to become blastocysts, they compensated with their quality, they compensated for the embryos which did not reach, because per blastocyst, the implantation rate was much higher.
So, no, but the thing what they say is these embryos which didn't make it to blastocyst, okay, they say that probably they would have not made even in the uterus.
Yeah.
When they do, but then that is very hypothetical, isn't it? I don't think there is any single paper to prove that an embryo which does well in uterus, do not well in the in vitro condition or vice versa. There is no evidence. It's just a hypothetical question, which we've been talking for the last, I don't know, from the time, people started to think about blastocyst culture, we've been discussing that. But we have no answer for that.
But the only way to find an answer to this question, see, this dilemma we face every day in the lab, that if the embryos had not been cultured till blastocyst and transferred on day 3, would they have implanted? Right? So the only way, so the one limitation is this is a retrospective study, and they have mentioned that in future a prospective randomized control trial needs to be performed in order to have a definitive answer to this question. That this is the only way we can find out whether our culture conditions are such that we are sure that an embryo which doesn't make it in vitro will also not make it in vivo. Right? And if we are able to do this, so because I am a true supporter of blastocyst transfer, and I believe that my laboratory can support that. That is why I have reached that place in my culture conditions where I know that if an embryo in vitro conditions in my laboratory does not form a blastocyst, then there is actually very little chance that it will implant, which means that my KPIs have led me to reach this stage. And so I follow the view in my laboratory, and when I counsel patients, and we have this conversation on a daily basis, where the embryologist and the patient are trying to figure out whether day 3 or day 5 should be done, is the fact that we tell the patient that if your embryo doesn't make a blastocyst in vitro, then there's probably very little chance that it'll make one in vivo, which means a day 3 transfer. And and for us, the most important thing is to be able to transfer a competent embryo. And we believe that by undertaking a blastocyst transfer, we are doing that. And especially in our country, where majority of the patients who are coming to us with multiple failed cycles, all of them have gone through multiple day 3 cycles. And so the only way of determining whether these embryos are actually any good or they are competent enough is to go till blastocyst.
So Gaurav, actually that particular point you said, like say if they had already undergone multiple cleavage stage embryo transfers, then the decision is very easy.
Yes,
like you don't want to put them through another cleavage stage transfer. But when they come for the first time, And then, like they are in that category where they will not be able to afford another cycle. When there is, all pressure on that single cycle, what would you do? Because I remember reading another paper which asked, when you have just one embryo on day 3, what would you do? Whether you would transfer it on day 3 or would you culture it to blastocyst? And there they have mentioned that by taking it to blastocyst, you are actually making the chances 0 in some cycles. Like if you don't transfer, then there is 0 chance. But if you're transferring, we can never say that with the cleavage stage that, the rates, even though, even if it is a 1% chance, 99% of the time, if it fails also, you are still giving that 1% chances. So what would be
but
your
what if that one embryo becomes a blastocyst? Then that's...
It is well and good. But the thing is, like, why aren't they
those
showing
38 which lost the option to even have an embryo transfer without we knowing what their outcome would be? That is disheartening. So we're not actually debating, Gaurav, when you say your lab KPIs, all of us have our lab KPIs, and that is good for good prognosis patients, right? And we have to understand that that's the only way we can determine our culture conditions and our performance in vitro. Our lab KPIs are relevant for in vitro status, right? So how much of that is applicable for in vivo? Like you said, if I get a blastocyst in vitro, I'm more or less confident that, in vivo, you would have got it. Or if I don't get it in vitro, in vivo, less likely. That is theoretically said. But in a poor responder group, I think also we need to look at those aspects where we have some papers suggesting that, blastocyst also leads to increase in large for gestational age babies, epigenetic alterations. All those things aside, when it is just the couple and us, somebody who's sitting with 2 and 3 day 3 embryos, there is, I think it is they who determine and the way we counsel. But ultimately, the cancellation rate is glaring up there, and I'm not seeing any benefit of taking it up if it's not giving me any reduction in multiple pregnancy rate, any elevation in ongoing pregnancy rate, any reduction
they are not saying any, there's no benefit, right? There's no benefit, but at least there's no harm also. That despite the cancellation, the blastocyst taking that strategy, so it's probably like a non-inferiority trial.
No. Harm is the cancellation rate. Harm is the cost burden to the patient to go through it again. So that is just not being highlighted there, right? In a practical scenario, you would look at that. Patient is going to say, okay, I didn't get a transfer. Next what? How much is it going to cost me? Correct. So that is...
And another thing, I also feel
so are
that
the patients who had a negative result, so are the patients who had a negative result after transferring day 3, they also had to go through another cycle.
No, I think, say when the embryo doesn't make it to the blastocyst, we are shifting the blame on the patient so that they say your embryo didn't reach blastocyst. Suppose if we transfer a cleavage stage and if the patient is negative, then we have to look for reasons to counsel that negative. So I think...
Which is very hard, And here at least we get some definitive information. If you're sure about your culture conditions, then perhaps transferring till blastocyst is the only way to determine if an embryo was competent. Because there are so many embryos which are, especially poor responders.
Somebody who's with poor quality oocyte, I wouldn't. It is not about my culture conditions, Gaurav. Everything is not only culture condition is my point.
We're not talking about poor quality eggs.
No, you have a poor responder with poor quality eggs, right? But still would have 1 or 2 good day 3 embryo. Am I going to attempt doing a blastocyst there? I doubt. Because I'm going to be worried if it comes from a poor egg quality, a poor sperm quality, whether, it is going to
But
move
then
on.
doing the transfer, how is it? I mean, like Dr. Sujata said, that our aim, is it to do an embryo transfer or is it live birth?
Yes, so as long as we're giving an embryo transfer, we're giving a patient some chance to conceive, right? In poor respond, I am very much...
Theoretically, you are giving some chance.
Transfer.
Theoretically, you are giving some chance, but the paper shows that that
There is no benefit. Exactly. So why would I do a blasto and take the excess cost burden on the lab, excess, attempt to culture them for another 2 more days? Why would I do that?
No, you are giving some definitive answer to those 38 patients that your eggs were not good enough. They were not competent. The embryos were not competent.
So, like labs are different, like have they mentioned in the introduction that there could be variations in the lab which can have a profound effect on the blastocyst formation. So suppose if we have to give some take-home message from, for the audience here, what would we say? Because, you are very confident, you are keeping track of your KPIs, you do this. But then can we just say that everybody take all your embryos to blastocyst, or you take your embryos to blastocyst provided these conditions are satisfied? What would be your,
No. So this study is meant for, see, you're dealing with poor responders and you are dealing with only 1 to 3 eggs. So this just changes the whole scenario. We are not dealing with 10s and 20s of eggs here. So here, the very fact that you are advising blastocyst transfer means that you are a very good laboratory, because the whole strategy can be highly counterproductive if your lab is not up to the mark. So, but the question remains that still doing this, is it beneficial, or is it even feasible for any laboratory which is even a good laboratory? They are trying to answer this question that, for example, they said that we have a policy, if the embryos are not good, then we will do extended culture. Because again, why? Because we want to, no matter what, we want to see if the embryos are fit for transfer or not. We will just not close our eyes and transfer embryos, poor quality embryos. But they are trying to determine that when you have good day 3 embryos, then taking them to blastocyst, does it help or not? So I think that in a way, I find this reassuring that if your things are in place, then perhaps making this choice, can be helpful.
So Dr. Rajvi, would you want to sum up?
Yeah, I would like to summarize. I think when a patient comes in, the primary objective is to give a pregnancy, live birth, pregnancy. The secondary objective is to answer the patient of why failure occurred. So if you are having embryos, only 2 to 3 embryos on day 3, this is the poor prognosis patient, then what are we really going to achieve by culturing further? Because blastocyst culture is basically taking away all those embryos which are not going to go further. On the other hand, if blastocyst transfer gave us 100% or nearly 100% results, then it makes total sense that, okay, we don't transfer on day 3, just go to day 5. And if it doesn't go to day 5, obviously, you are not going to get a pregnancy. But in this case, even after blastocyst transfer, we are not getting anywhere close to an 100% mark. And all we are doing is deselecting embryos. So in my opinion, when we are not debating blastocyst culture versus day 3 or day 5 transfer. We are debating in this group of patients who are having just 1 to 3, not even 3, 1 to 3 day 3 embryos. To my mind, it makes sense since it is making no difference in the outcomes, why go and culture further? Anyway, whenever we are in the lab, best KPIs, but still, we are not achieving anything great, I would feel. So I would say
I noticed that half the transfers in day 3 were fresh transfers and half of them were frozen. Whereas in blastocyst, 25% were fresh and 75% were frozen. Am I correct?
Yes.
Right.
That's a big variable.
That's a big variable,
Yes.
That's also a big variable. So if they had frozen all, because we know now that there's a substantial difference between fresh and frozen transfers.
No, the thing is, if they had frozen even cleavage stage embryos, I'm sure several cycles would have got cancelled, because survival rate of a cleavage stage embryo is much lesser than that of a blastocyst. So, maybe they would have cancelled some cycles there also. Probably. But if it is because it is fresh, mostly fresh transfer, they didn't have any cancellation.
So actually the study design, what they did was quite variable. And so I was a little surprised that there were such confounding factors, and at the end they are looking at clinical pregnancy and ongoing pregnancy rates, where there was such a huge difference in the number of fresh and frozen transfers.
Yes.
Only thing it sort of tells us is that even if you have few embryos, you wish to go to blastocyst, you're not losing anything. But even if you're doing day 3, you're fairly safe. I mean, that's the kind of conclusion. Maybe we can see from the audience, maybe they can give a thumbs up sign if they are going to go for blastocyst. Literally, it's a group who thinks it's blastocyst for all kind of thing. They can give a thumbs up sign, and if they don't agree to it, let's see what the general. I'm sorry we don't have the polls on, but we can just see what people have to say. Maybe you can give your opinion in this manner. Time.
So in the meantime, I have a comment on this, that probably this particular study suffers a lot of limitations. And this should not be taken as an example to as a deciding factor whether to go for blastocyst for all. But what I see, and I would like to have a quick comment from our panelists and speaker regarding a practice that is very prevalent nowadays in our country regarding the culturing all the embryos unto day 5 and without seeing them on any day in between.
I'm not for it, if I may answer it first,
Yes,
because
please.
I would like to see it at least, if not on all days, but at least on the day of check and on day 3, definitely. So like, I'm not for keeping them like that, because there could be a lot of abnormal fertilizations. There could be a lot of other things also. And even a 3PN embryo can result in a very beautiful blastocyst. So I'm not for it.
Also, they don't even check on day 1?
Mm.
Yeah, that's what.
There are some who skip the FERT check as well.
Yes.
So because most of them, they do ICSI for all. And
So-
they just ICSI them, keep them until the day 5. And the worst thing is that depending on the result of your embryogenesis, they straight away advise them to go for a donor cycle.
So for me, what I also do not agree that the embryo is directly seen from oocyte to blastocyst stage. Somehow I find it, if I may say, criminal, because I think the couple has every right to know what is happening to the embryo, right? If not on daily basis, they are the ones who should be a part of the decision-making process. It cannot be unilateral that we decide for the patient. It has to be informed consent. So if the couple is not aware of how many have fertilized and how they kind of look like at cleavage stage, what are the chances of they forming a blastocyst, I wouldn't like to be in that place where I don't know anything happening and directly I'm called on day 5, either take a transfer, nothing has formed a blastocyst. I mean, yeah, that's something I wouldn't be comfortable with. So I wouldn't agree with that kind of approach.
Also, I have another point, that this is a huge risk, because you will not be able to assess how your culture conditions are going on. I mean, this is assuming
Miss all the KPIs.
This is actually being very arrogant that every single day your system is near perfection. That for 6 days you're actually not watching. How will you know that all the cycles and all embryos and all patients are all progressing? In case there is a problem, you will not be able to take any corrective measures.
Yes.
So that's the whole point of getting this point on the table. So my message to all those aspiring embryologists or the junior embryologists or even the senior embryologists who are practicing this thing, I request them sincerely that unless you have a time-lapse imaging system and you are analyzing your data religiously, please see what is the fertilization rate and at least that day 3 embryo formation rate before you decide to go for blastocyst for all.
And
I think you raised a very valid point, and yeah, this is extremely crucial that we communicate this message across.
so probably also people should know that with ICSI for all also you can have 3PN embryos.
See, 3PN embryos, and also infection can be there, bacterial contamination can be there. You just pick your dish on day 5 to see everything arrested, degenerated with bacteria everywhere. You know, these chances are there, even if it is less, but still there are chances. I don't think anybody should take that kind of a risk.
Yeah, just to do something without monitoring, it's like the patient coming into the clinic and we don't even bother of taking the history. So would a clinician ever start any procedure without any history at all? So it's the same. We want to know the history of the blastocyst if it has developed for the last 5 days. So
These are
I think
called lazy embryologist protocols. We want to lessen our work
I
burden.
wouldn't even say it's worse than being lazy. Lazy is something if it doesn't cause any problem, but this is something like you yourself use the word criminal.
If this
It's
level
rare
of
for rare
uninterrupted,
cases.
if this level of uninterrupted culture is desired, then you may as well go and buy a time lapse.
Yes, exactly. And I really it would be interesting to know if they're not interrupting the culture, how good is the pregnancy rate? How is it actually helping them? I mean, we have talked about all the disadvantages of not knowing that, but I would like them to come forward and say, how much did their pregnancy rate elevate when they stopped observing the embryos from day 1 to day 5? Is it really worth taking that risk? And
does it significantly improve the blastulation rate?
yes, I'm not aware.
No, it doesn't, because even with time lapse, it doesn't.
There is a question here on time lapse by Devi. And I see the thing is this time lapse, I know there are a lot of parameters like, the cleavage from the first cleavage and then from the zygote to first cleavage. There are a lot of parameters which have been shown to have an impact on the viability on the blastocyst formation. But for people who do not have time lapse, if you are asking for any one particular marker which can predict, I would say that it's the compaction of blastomeres, which you observe on day 3 is a very good indicator. Like if you see a very good 8 cell, but the blastomeres are all perfect, round, with no fragmentation, but still the point of contact is very less, then very likely that it can be a slow growing embryo or, it can arrest. But if you find nice cell to cell contact on day 3 morning, most likely they will end up in blastocyst. This is just an observation.
So if there's anything more, if any of the participants would also like to comment, otherwise we can end the session. So I think there have been a couple of take-home messages. Please watch your embryos daily or at least frequently, not so much to interrupt the culture extensively. Don't go for blastocyst for all as a routine protocol. Although the paper does say, but then many of the flaws of the paper have also been, or limitations, I would say, have been brought about. So thank you, Dr. Sujata, for the very clear and crisp presentation, and Gaurav and Varsha for the discussion. And thanks, Sanjay. And thank you all for joining in. We meet again after 2 months for the next journal club. You're welcome to send in your suggestions at any point of time, since ACE is our academy. And if you have any other specific topics to discuss, papers to discuss, please write to us. Thank you. Thank you all.
Thank you all.
Thank you, Dr. Sujata. Thank you.